Hello, my name is Fong Yee and I'm an F1 in Queen Elizabeth Hospital. I've worked in acute medicine, geriatrics, and now I'm on respiratory. This lecture is part of a series that will be uploaded once a week until August, and today I'm going to talk about the role of F1 in medicine. So a typical day of F1 in medicine is quite similar in different wards. So you would have a ward round that could be in the morning or afternoon where the MDT come together and go through the patients. And then the ward round, it's usually led by the consultant, but it could also be the reg or SHO, or sometimes yourself. After the ward round, you would do any urgent jobs, so that would be any urgent scans, referrals, or any bloods that hasn't been taken by the phlebs. After lunch, you could do rest of the jobs from the ward round. The blood would usually be back in the afternoon, so check for any abnormalities and act on it. For example, if there's raised inflammatory markers, then you might need to do a septic screen, and if there's any electrolyte imbalance, you might need to treat it and replace it. Updated next of kin is now a big part of our job because most of the time they're not allowed to visit due to risk of COVID. So that unfortunately takes a lot of time, but would be a good practice to keep them in the loop. And then if there's any urgent jobs that hasn't been completed, then you need to hand over to the on-call. So ward round documentation is an important role of F1. You need to document the date and time. I like to document the current issues, list them, and under each issue list what you've done and the outcomes of it. I'd also like to include background and investigations that has been done for this patient, and that would really help with the discharge summary once you come to it. EDD is a good one to document because then the other members of the team, for example, social services and PTOT, would have a date to work towards. Examination findings and observation also need to be documented, and then the most important part is the plan. So document the plan clearly and ask if there's anything that you don't understand. So for example, make sure you know the indication for any scans and referrals, and that will help you with the job later. Make sure you've documented the person leading the round, and then put your signature and bleep at the end of the ward round documentation. If you were to lead independent ward round, there are things that you need to review before seeing the patient. So look at the observations, check the vital signs. Bowel chart, food chart are important in geriatrics. Fluid balance is important in all specialties, but it's always poorly documented. Check the most recent bloods, review the drug chart and change anything if necessary. For example, if the patient has been hypertensive, stop or hold the antihypertensives. If there's, for example, hyperkalemia in the drugs, then stop ramipril. Any dehydration, if it's severe enough, consider stopping the diuretics. Check if the patient have appropriate VTE and antibiotics. Make sure the duration of antibiotics is appropriate because that could help avoid complications like C. diff, colitis, or leukopenia if it's unnecessary. Check the visa status. It's now quite well documented because of COVID, but it's always a good practice to make sure that the visa status is appropriate for the patient and it has been discussed with the patient and the relatives. Check if there's any new documentations that you haven't seen and need acting on. Other things include ventilation sheets. It's important in respiratory because you want to know how long they've tolerated an IV overnight or over the 24 hours. Drain output is important for chest drains and acidic drains. Serial ECGs are often done in cardio department, so you need to check if there's any new ST elevations or dynamic changes that needs acting on. So when you're with the patient, the minimal of examination would be the alertness, cardiorespiratory, abdominal examination, and look at the legs. So if a patient is particularly MFFD waiting for placement, that sort of thing, I would say patient is alert and sitting in chair, heart sounds normal, chest clear, abdo soft non-tender, bowel sounds present, legs nil edema, calf soft non-tender. So that would cover for any HAP or DVT that could have developed in the hospital whilst waiting. So check for any lines, check the cannula, make sure that it's clean and not painful around the area. Check if it's actually needed, so if they're no longer on any IVs, then just ask the nurses to take it out. Check the catheter, make sure that it's draining urine and not blocked. Check the color of the urine, because sometimes you might pick up dehydration or hematuria from the catheter bag. So if you're doing F1 in medical wards, you might have clerking shifts. So in clerking, you would take a history that includes presenting complaint, history of presenting complaint. It's also useful if you can have a GP record to refer to for past medical history and drug history, but if that's not available, patient sometimes can bring their own bag of medications or a prescription from the GP or pharmacist that you can refer to. Social history is important, so that will help tell you the baseline of the patient. So other than smoking and drinking and recreational drugs, ask if they live at home, whether they are independent with activities of daily livings. Check how they usually mobilizes and how far they're able to mobilize before they stop. Family history is sometimes indicated if it's a, for example, a young patient who had a sudden collapse when exercising. See if they've got any family history of sudden death. And then examination, I usually include cardiorespiratory, abdominal, CNS, PNS, and fluid status. It's always useful to do a baseline AMTS, just so that if the patient is confused in the ward, you would know if it's a baseline or if it's new. So it would be the documentation of examination would be quite similar to the ward round documentation, except I would drop down the GCS and say CNS NAD power 5 out of 5, AMTS 10 out of 10. Investigations during admission should at least include chest X-ray, ECG, bloods, and a form of blood gas, either VBG or ABG. So depending on the history and examination, you would formulate your impression, that's the differential diagnosis, and depending on that, you would formulate your management plan, which could include any scans, cultures, IV fluids, and you should do the urgent jobs even if the consultant isn't here to post-take yet. So for example, if a patient has come in with a 4 who's also on anticoagulants and is now confused, then you need an urgent CT head. And if the patient is septic, you might need to do the septic screen that includes blood culture, urine culture, sputum culture if possible, and start the antibiotics fluids if that's indicated as well. So referrals is something that we do daily in medicine. So it's very helpful if you are able to find out how to do referrals to all these different specialties and departments from your local hospital from your seniors before you start. That would save a lot of asking and looking around when you actually need to refer someone. In med school, we're taught SBAR, which stands for Situation, Background, Assessment and Recommendation. Some people like it that way, but a lot of people find that too long as well. So I would usually start with a headline, so what you want them to do or what would have been interest for them. For example, if you're vetting a scan, you would say, I'm an F1 from Ward 19, I'm trying to vet a CTPA for this 76-year-old lady who's come in with type 1 respiratory failure, tachycardia with a D-dimer of 600. Then that's very clear information and all the indications that would warrant a CTPA to rule out PE. For specialties, I would usually refer the patient with a headline that's actually relevant to this specialty. So, for example, I'm calling to refer this patient background alcoholic disease with tense ascites. So this is a 50-year-old gentleman who came in with a very distended, painful abdomen. We've tried diuretics, but it's not resolving. So would you mind to come and review the patient for consideration of an ascitic drain? Other people that we often refer to as speech and language therapists for communication and swallowing, dietitians as well for refeeding or NG feeding or alternative feeding. We also often refer to palliative care for patients who are end of life or for fast track referrals. So MDT meetings can take place during the board round or in separate settings. So the medics usually would update the medical plan and let them know what the current issues is and estimated date when the patient would be medically fit for discharge. Nurses could tell you what the care needs of the patient is. For example, they need assistance of 1 to transfer or need assistance of 2 to mobilize to the toilet. And you could hand over to a nurse for any investigations that are required. For example, you need some stool or urine sample or lying and standing blood pressure for such patient. PTOT would also assess the care needs of the patient. They can advise on the rehab status and duration for the patient that can affect the discharge plan and destination. Social services would collate all the information of above and arrange the care packages and placements. Discharge summary is a very important document that F1 do. So because the patient and GP would only have this letter to refer to for what has happened in the hospital and what else needs to be done after they are discharged. The hospital also earn money from the discharge summary because they can code the diagnosis and investigation that has been done for the patient to claim money. So what I usually put in the discharge summary is quite similar to the clerking. So I will start with presenting complaint, I would say Mrs. Smith presented to the emergency department with shortness of breath on this date, and then include a bit of the background, mainly past medical history and drug history and social history, and then I'll list the issues during admission and what has been done for each issue. Includes some summary of the investigation that has been done, so that the GP could have a bit of a record. And then the most important thing is the discharge plan. So mention any change of medications, any need for GP follow-up, hospital follow-up, so that the patient can remember what needs to be done and when they need to come to the hospital for follow-up. So lastly, some general tips for starting F1. Try and gather as much information as possible before you start. Don't be shy from getting involved. Get yourself open to gossips, because then you'll learn a lot about what is the best thing to do in different situations. Also, get your portfolio sorted early. In F1 you would have ARCP, and that includes a lot of mandatory sign-offs. A lot of people wait till the end to do it, so consultants are often bombarded by like 10 mini CAXs and 20 CBDs to sign, and they're less likely to sign it if they have so many waiting. So try and do that early, and that will leave less stress towards the end of the placement. Also, take opportunity to learn. There's a lot of procedures that could take place in a medical ward, for example LP, central lines, drains. So if anyone is doing it, tag along and look at it, and after seeing one or a few, when you feel confident enough and that you know what the steps are, get someone to supervise you doing it, and then once you're comfortable with it, then you can start doing it independently or even teach other people to do it. One thing that I've learned which was really useful was ultrasound guided cannulation. That hasn't been taught in medical school, but it's actually a very useful skill to learn whilst you're in medicine. Also, be aware of the local policies for never events, and common never events are prescription errors, misplaced NG tube, and wrong group and safe, wrong bloods given to the wrong patient. So in our hospital, you can only use an NG tube if it has acceptable aspirate pH, or if the chest x-ray has been reported as NG in situ by a radiologist. So even if you are able to tell that the NG tube is definitely below the diaphragm and in the stomach, you're not allowed to start the feed until it's been formally reported. So check your local policies and make sure you're not a victim of these never events. Make sure you always prescribe carefully. It's very easy to make prescription errors in terms of the dosage and frequencies. Always have your BNF next to you, and microguide is very useful for hospital local guidelines for antibiotics. Lastly, don't do anything that you feel uncomfortable with. Sometimes the benefit of F1 is you can always seek senior advice, and if someone is pushing you to do something, even though it might make sense but you feel uncomfortable doing it, ask a senior whether it's the right thing to do. So that's all for the lecture. If you've got any questions, drop me an email, and thank you for your time.